Good morning. I feel like I'm in the wrong session, so somehow we're not talking about deliveries or C-sections, simply talking about stress incontinence and management of stress incontinence by slings, and then what happens when things go wrong, which is what this topic is about. So when women have these problems, we've been struggling about how to help them regain continence. Very few of them really wish to have another sling since the first one failed and had to be removed. So we've basically went on to a bulking agent for that condition. I have no disclosures. So as some of you may know from prior work that we've published and others, about 60% of patients will have stress incontinence to some degree after sling removal. And macroplastic has been around for a long time. It was first described in 1991. It's been used for the treatment of stress incontinence secondary to intrinsic sphincter deficiency, not so much for hypermobility. And the outcomes have been examined in some papers, but very little has been written about after sling removal. So this is the goal of this work, is to present our experience with this injectable agent. We started injecting with macroplastic in 2011 when collagen came out of the market. At the time, I was interested to find an agent that had been on the market for a while, which was the case, one I could see by ultrasound, since we had a fairly large publication on collagen, followed by 3D ultrasound. And macroplastic, as you'll see, is extremely ecogenic. And then I wanted to make sure that basically the injection technique was fairly straightforward, and it was. In this group of women that we're presenting today, they were non-neurogenic, they all had ISD, they all had a suburethral sling removal, and they all got macroplastic injection, no other injectables. We excluded people that had less than 6 months follow-up, neurogenic bladders, patient who had a suprapubic tube catheter, history of urethral erosion, a fistula, or anybody who had macroplastic with a concurrent surgery. The procedure was performed by myself and another colleague. We all use light anesthesia. The injection is a little bit painful. Some have done it in the office setting, but we've tried to do it otherwise under anesthesia. After 2 prior surgeries, a sling placement and a sling removal, it's a little bit easier to deal with the difficulties of this injection. We use a 21-well scope, that's standard, and a 25-degree lens. Typically inject in 2 sites, 3 and 9 o'clock. You'll see a movie in a few seconds. And we inject about 5 ml, 2.5 ml on each side. Let's see if the movie goes through here.
At the start of the procedure in this 67-year-old woman with stress urinary incontinence secondary to intrinsic sphincter deficiency, the needle is primed inside the bladder to clear the air out of the macroplastic syringe. Now, the injection is started at the mid-urethral level on the patient's right side, with the needle introduced all the way to its hub. One can see the gradual rise of the mucosal layer towards the midline. After the needle is slowly withdrawn to avoid surface tear at the puncture site, a 10 French rubber catheter is introduced to drain the bladder. Of note, the catheter remains in place and does not slip out, attesting to the internal tightness of the urethral lumen produced by the macroplastic injection. A second syringe of 2.5 cc macroplastic has been loaded in the gun, and a contralateral injection on the patient's left side is now started. Note the gradual introduction of the first and then second black markers on the needle shaft until reaching the hub. Here, again, one can observe the gradual internal shift of the urethral mucosa towards the midline. Once the injection is completed, the lumen is completely closed despite the irrigant flow. 6 weeks later, a 3D vaginal ultrasound with finger probe identifies the white echogenic pattern of the macroplastic injection around the urethral lumen in a horseshoe configuration.
So this is the technique that we've been using. Now, how did we analyze our data? At baseline, we had pad usage. We had the short form of the UDI-6, which are 6 questions, validated instrument. We had a quality of life question score. And then we had urodynamics at baseline with lick point pressures, PDAT Qmax maximum flow, and post-void residuals. In follow-up, we had the same repeat questionnaires and 3D ultrasound. Now, the 3D ultrasound was done typically at 6 to 8 weeks in the first return visits, and then afterwards only as needed, and especially if there were failures or decision for injections. Our success was a composite score. We use a questionnaire score, the question 3 of the UDI-6. That's a question about stress incontinence specifically. It's scored from 0, none, to 3, and 0 to 1 is none or rare, and no additional anti-incontinence therapy. 70 women met our study criteria out of 76. That's the age distribution here. You have the hysterectomy history for those interested. You have the type of sling that led to this reoperation dominated by retropubic sling, which is no surprise. Our mean follow-up is about 4 years. And the time between the sling excision and the injection macroplastic was about 18 months, a year and a half. Our success rate after one macroplastic injection is 46%. This is in this column. Then some chose to get a repeat injection. So this is the incontinent group after one injection. That's the incontinent group. Of that incontinent group, some get the second injection. And of those, 16 additional patients being incontinent. So in total, and then some elected not to do anything, and a few went to pubovaginal slings. Overall rate was about 69%. So about 70% of patients with 1 or 2 injections achieve our success definition. Of those who failed, we studied them fairly intensely trying to figure out what happened with those patients. The macroplastic injection was successful because the volumes were quite high, as shown here. Those who had the ultrasound, the volumes were high, so they did not fail because the macroplastic was not there. They failed probably because of the severity of their incontinence to start with. But if you look at subjective outcomes, many of them were quite happy, and that's why many of them elected not to do anything, with a improvement rate about 83% subjectively and pad usage reduction in about 80% of them. So in conclusion, macroplastic does help women who have this condition of stress incontinence, which is bothersome after sling placement followed by sling removal for a complication. In some of them, you have to tell them when you first discuss this option with them that they may need a reinjection. We use the ultrasound to guide this reinjection because we can tell pretty much whether it's completely horseshoe or if there are areas where we can tweak and add some more. And those who fail, many of them decide to basically be observed and don't go any further. A few of them end up having a fascial sling. Thank you.
Thank you. This is an interesting study. The rates of sling removal vary considerably in different countries, but this is obviously a potential method to use in these women who've had their sling removed. I see Jonas, you have a question? Jonas Gunnarsson?
I was wondering, you were only looking at patients with ISD. I mean, surely there are a number of patients who have sling removals who do not have ISD, even after sling removal. Why did you exclude that category? You would expect somewhat higher results in such a group.
You're talking about women who have still hypermobility after sling removal?
Yep.
Yeah, this is a different group. We don't really use bulking agent for that. The data is pretty weak on bulking agent for hypermobility. So we have used other techniques of vaginal wall suspension, needle suspension to help them out. So they were not at all in this group.
Actually, there was a randomized control trial from Finland showed at the NUGA meeting a year ago or so that showed that the bulking agents in this subset of patients wasn't all that inferior to retropubic slings. It was only in the order of 15% less effective. So,
well, I've not said it was not effective. I say it was not part of the inclusion for this study.
okay.
They had
So
to, have a well-supported urethra with sphincteric deficiency.
So what treatment option would you have for these other patients?
If they have
non-ISD,
stress incontinence with hypermobility, like any hypermobility technique that we use in our centers, which is the intravaginal suspension, which I presented yesterday with very long-term success at mean follow-up of 15 years, ranging 10 to 25 years.
Thank you.
The success rate after one injection was 46% and 59% after 2 injections. And you have a long follow-up, 4 years, which is impressive, I think. Do you have
And I have to say, the data that we present was at the last visit.
Yeah,
Yeah.
yeah. Would you care to speculate why the women who didn't respond, what was the reason? Do you have any ideas? I realize this could be more speculation, but you have been working with this now several years. We would like to know your experience.
Yeah, I think there's a fair amount of damage that occurs after sling placement, and I'm sure that removing a sling doesn't add to that. So when you think about the mid-urethra, that's where the blood supply, the innervation of the urethra goes. To me, I would say that that's probably the wrong place to ever put a synthetic material, but that's the way it is. And if you look at ultrasound prior to the surgery like we have, many of those things are quite deep in the urethral wall. They were probably not placed there, but they probably traveled there over time. So they've induced damage to the urethral wall. So I think the injection is the best we can do, but there's a limitation, and some people have really severe form of sphincteric deficiency that an injection cannot completely fix, because the volume that we've injected were much higher than the volumes we got with collagen years back, and we have, I don't think I can put more macroplastic there without running the risk of, an extrusion at some point. So I have to say that when you look at them, they have a very fixed urethra. The macroplastic is visible on cystoscopy, but they're standing up, they still leak as much as they did beforehand. It's a bit frustrating. You would think they would be obstructed, but they are not. They basically still have significant sphincteric insufficiency, and they respond well to a very loose fascial sling because you don't need a lot to get them dry at this point.
The reason I asked the question is I was thinking about the reason why the sling was removed. And that could
the sling was removed for a variety of reasons.
Different types of damage,
Yeah.
And that may relate to the success rate.
I think you're right. The indication for removals were a variety of indications ranging from obstruction to urge incontinence and urinary tract infection, pain, and so on.
Okay, well, oh, great.
Steven Stratford, the Netherlands. About the use of foreign body material. First of all, you remove the sling, which is a foreign body, and these patients were not happy with it for several reasons, I understand from what you just said. And now you're going to implant another foreign body, macroplastics. What's the feeling of your patients about the second time usage of foreign body? And in the US, it is a hot topic.
Yeah, it's a very good question. All the bulking agents are foreign agents, whether it's collagen or we used to have other agents in the past. People have to decide between that, which is a 15-minute Mohs procedure with fairly decent outcome, versus going on through a fascial sling, which is the next best option after that, which is a much bigger operation, as you know. So that's basically their decision choice. Some have opted for a sling up front, but most of them are happy to try, this simpler operation. We have long-term data now to offer them, so I think we feel more comfortable that this is not a bad option. We will present tomorrow a series of extrusions, so they can happen. Patient needs to be aware of that. We join with a group from the UK as well in that presentation tomorrow, so I think there are some risk, but there has been risk with bulking agents, so we know that. I don't think they're any worse than they were. I think the urethral wall is pretty weaker in these patients, and I think the macroplastic kind of goes to the side instead of necessarily compressing medially, because there's no musculature around the urethra to hold the macroplastic as well. So that's why I think the volume and the results don't necessarily match up very well. And we've tried by ultrasound MRI to predict the shape of the urethra before this injection to see who would be the best person to respond to it. And at this point, we really can't sort out how good that musculature is.
Right, thank you.
The time is actually up, but a quick, short question.
Right. Have you had any cases of microplastic migration? And if you did, how did you manage them?
We've not had microplastic migration like to the brain or other organ like the lungs or anything else. We've had extrusion, mostly in the urethra, which is fairly straightforward to deal with. The challenge ones are in the bladder neck. They oftentimes are unrecognized unless you do flexible scope and you flex back to see where that extrusion is. And if it's calcified and a bit yellowish, it may be hard to see. Those have to be resected, and then you start from basically baseline again. You have another incontinent patient, and at that point, the only option left is a fascial sling.
Did you had any abscess formation, with
No, we've not seen
short
abscess
question.
formation. Yeah. No.
I must interrupt. I'm sorry.
I'll be here for a little while. Other people have questions.
Okay.
Thank you very much.
Thank you very much indeed.